This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week I'm coming to you from the W.L. Nugent Cancer Center. My guest is Dr. Michael Payne. He is a radiation oncologist at KRMC. Dr. Payne, welcome.
Thank you.
I should say welcome also to KRMC. You're a pretty new guy around here, right?
I am. I've been here for 3 months now.
3 months. How has it been?
It's been great.
Yeah?
Yes.
I want to talk all about the specific cancer treatments that you're doing and what brings you here and what some of your medical interests are. It's your first visit, so I'd also like to just do a little getting to know you, if that's all right.
That's okay.
Where do you come from?
I am originally from Chicago, but I came here from Springfield, Illinois. I didn't spend much time in Springfield. And before that, I was at Cancer Treatment Centers of America for 10 years.
What, as you look back on your career in medicine thus far, what was the interest for you, or what led you into a career in medicine?
The way my mother tell it, I've always wanted to be a doctor since I was little. So as far as I can remember, I've always wanted to be a doctor.
It was just a thing.
It's just a thing, which is surprising because I grew up on the south side of Chicago, and there were not many doctors in my life at that time.
Were there any medical people in your family?
There were not, no.
It just happened.
Yes.
That's really interesting. And did you, as a kid, did you excel in science?
I did. I was always tinkering with things and taking things apart. Yeah. I actually got an undergraduate degree in engineering, so some people would say I took the hard route to becoming a doctor, but I love just learning how things work and why they work the way they do.
And that very much informed your choice in specialties when it came to medicine.
Yes, it did.
At what point in your training did you decide you wanted to go into oncology, specifically radiation oncology?
It's actually my last year of medical school. I went to medical school thinking that I would be a surgeon, and I did the surgery rotation, and I didn't like it. The surgeon said my medical school were grumpy.
Well, I mean, that was a major factor?
That was a major factor. I didn't want to be grumpy. I mean, have a grumpy life.
And I'm sorry to interject, but I think people don't necessarily realize the attendings and the other students who come before you, they have a major impact on the way that you view medicine, right? I mean, because for a lot of them, they see themselves as gatekeepers, and it's their job to terrorize the new students. Is that true?
That is absolutely correct, because I didn't learn there were nice surgeons until I graduated medical school.
Well, I mean, we're talking about I don't even know. I don't even know if I believe this, but I'm going to say it. We're talking about trying to create this kinder, gentler world and have school be more accepting and have a work-life balance. And I mean, these are buzzwords. These are terms that we're using, right? But I mean, is there still a fair amount of hazing that goes on in medicine?
Luckily, they've taken a lot of that out. There's still some doctors who feel I went through it, so you have to go through it.
Yeah.
But I think learning is much better when you don't have that negative stress, because there's going to be stress for just going through medical school and training, but that negative stress actually makes it much worse, in my opinion.
Yeah, I don't know who learns well in those circumstances.
Yes.
But right. It's like, well, we're passing on, they terrorized us, so now we have to terrorize you.
Exactly.
Okay, so you were saying you didn't enjoy surgery. What was it about surgery that you said, this is not really for me?
So the first thing was that they got up really, really early. I'm not a morning person.
Nor am I.
And the second thing is that they at the medical school that I trained, they tended to be grumpy.
Yeah.
And I didn't see myself, I'm not that person. I don't like to be grumpy, so I didn't see that as a career for me.
Yeah.
When I was in my last year of medical school, I had to decide a career, and so I lucked upon radiation oncology, and in an unfortunate way. My grandmother was diagnosed with leukemia in my junior year of medical school, and in my senior year, I had to drive her to her radiation treatments because she was receiving radiation. And before that, I didn't know about radiation. And as I was learning more about radiation, taking her to her treatments, I thought that would be a great fit for me. It uses a lot of physics, which is science that I like, and also there's a lot of patient care. There's direct patient care, and I spend a lot of time with patients, which is another thing that I enjoy.
That is very interesting. So that started you hearing about her treatments, and so you started doing research on, based on that. What is this career, and what might it hold for me?
That's right, and I actually just saw that and did a rotation at my medical school, and I did a rotation at a couple of other medical schools, and decided at the last minute that I wanted to do that, so I applied and got in.
That is amazing. And radiation oncology is this field. Well, there are some fields in medicine where you're always with patients all the time, right? And there are others where you get to kind of be more reclusive. You get to work more in the shadows. And I think that suits people who are maybe a little more introverted.
Yes.
But with radiation oncology, it sounds like you have the opportunity to do both, to work with the technology you enjoy, but also to serve the patients.
That's correct. And that's, like I said, it married my two loves, patient contact and also the science.
If it's not too personal, how did things work out for your grandmother?
My grandmother died about a year later.
Yeah.
So.
Yeah, I'm sorry. I was hoping for a happier conclusion to that story, but in a way, it opened a door for you, and
it did.
Yeah, I'm not trying to force that narrative, but it just seems like. Right?
Yes, yes, her and her suffering and her treatments. I decided on a career for my life, and she helped me in that way. And luckily, she lived long enough to see me graduate from med school, and decide on that career choice.
Do you find that a lot in oncology, that sort of story?
I do. So for radiation oncology in general, radiation and medical oncology, there are two pathways to it. One is you know somebody who's doing it or has done it, and specifically a parent, grandparent, uncle, aunt, or you experienced it on the other end where you had somebody who had to go through the treatments. Either you're the caregiver or you were a patient yourself.
Yeah, I'm thinking of your colleague, Dr. Edgardo Rivera. He's talked with me. This is not betraying any confidence. We talked about it on the radio before, but he was in medical school, not really sure what particular path he would follow in medicine. And at that time, his brother developed cancer, and he watched all that his brother went through, and it was a calling for him. And just, I'm just thinking about your story, and there's something there. There's some kind of path, right?
Yes, there is.
Gee, thanks for sharing that. I appreciate it. I hope it's not too personal.
Oh, you're welcome.
Really interesting. I love finding out where people come from, you know? There's so much that goes into becoming a doctor. With all due respect to other careers, you can do other kinds of jobs, and they can be just jobs. But medicine is a huge hulking beast. It's going to take over your life, and you better love it, right?
It does take over your life because it takes so long to get there. By the time I was done my residency, I had colleagues who had been working for 10, 15 years in other careers.
Right.
So.
Yes. We're talking a little bit about some of your adventures and your different training that you went through. Your resume is mighty impressive. We talked about your undergraduate degree in biomedical engineering. You attended Rush Medical College in Chicago. You later completed an internship in internal medicine at the University of Illinois and a 4-year residency in radiation oncology at the University of Kansas, the final 2 years as the chief resident. And then later you had a fellowship in radiation oncology at New York Presbyterian Weill Medical Center. Did I get all that right?
New York Presbyterian Weill Cornell Medical Center.
Weill Cornell Medical Center. Yes. Thank you. That's a big resume. So as we look at your career and the twists and turns that you've had that have led you here to the desert, when you came to KRMC to check out the facilities and to meet some of the prospective staff that you'd be working with, what did you find here?
I was impressed because sometimes you go to small town hospitals and you see not the best as far as equipment and personnel. Not their fault because you need money to buy equipment, and small towns don't usually attract the best of the best just because they're small town, unless you really want to be there. Just the nature of the way things are. But when I came here, I was really impressed. The other doctors seemed top notch. The staff seemed great, and they had really, really good equipment. That's one of the reasons that I decided to come here.
I mentioned your colleague, Dr. Edgardo Rivera. When you're doing your work day to day, are the two of you collaborating, or do you pretty much have separate workloads?
We collaborate all the time because we have patients that we treat together. Because a lot of patients receive radiation and chemotherapy. About a third of cancer patients receive radiation, and almost all receive some type of chemotherapy. And so we collaborate all the time in the hallways, and even we have even formal collaborations in something called a Tumor Board.
Oh yeah, could you tell me a little bit about the Tumor Board?
Sorry, Tumor Board is a collection of doctors, usually a radiation oncologist, a medical oncologist, a couple surgeons of different types, a radiologist and a pathologist, and other personnel, ancillary personnel, who get together and we discuss usually challenging or difficult cases, just to get a consensus of how to tackle that problem, how to treat the patient.
This multidisciplinary approach, the idea is you bring in all these different specialties and have them collaborate, and everybody has a little bit different lens through which we see the situation.
That's correct. And it helps for a lot of patients who are difficult that you normally wouldn't find in a textbook.
Let's talk a little bit about some of those difficulties or some of your interests. When you treat all types of cancers in adults, are there types that are particularly challenging or maybe that you find particularly interesting?
I treat all cancers. My particular interests are in stereotactic treatments. I think we're going to get into that more later.
Yes, definitely.
And also brachytherapy.
Which is?
Brachytherapy is, so brachy means close to, therapy is radiation therapy. So it's putting the radiation in close proximity or directly into the cancer. And you do that using needles or probes or things like that. As a service that we don't offer at Kingman right now, but we are definitely looking into it since I'm here.
Very interesting. I think we're going to come back to that too. Yes. I've mentioned this with Dr. Rivera, but each time I've visited with him on the program, I've said, so, as you look into your crystal ball, what's ahead? Well, he's like 4 for 4. So it tells me the guy has some pull and he can make some things happen. You mentioned Sbrt, or stereotactic body radiotherapy. Did I get that right?
Yes, you did.
Can you tell us a little bit about that? What is that?
So traditionally, the way radiation was done, radiation was discovered back in 1800s. Marie Curie was very instrumental in that and using it for treatment of cancers. And the way we did it back in 1800s was patients got one big whopping dose of radiation, and they usually didn't do well because that can kill patients.
I was going to say, probably not. Yeah.
And slowly we learned over time that if we gave radiation slowly over a matter of weeks to months, that it could kill the cancer while the normal cells recover. Because radiation, when it's given to a patient, can damage all the cells that it go through, normal and abnormal. The difference is that when a cell becomes a cancer cell, it loses the ability to repair radiation damage. And so we use that to our advantage, where we give radiation, it kills the cancer cells, but the normal cells recover.
Okay.
But traditionally, the radiation treatments were anywhere from 4 to 10 weeks, every day, Monday through Friday.
Yeah.
And in the last 20 years, there's been a revolution in radiation treatments, and that we started looking. They started in Europe and Canada, in places where socialized medicine. Because what they learned is that they can't have a patient getting 9 weeks of treatment because they had too many patients and not enough resources.
Yeah.
And so they started looking at giving, what if we give patients more dose per day or more radiation per day and less treatments? That way we can get those treatments compacted, get these patients out, get new patients in. And they started studying that, and what we started finding out is that it works, and it works well in a lot of cancers.
Interesting.
And so now in the U.S., especially with COVID, which has been a big push to doing this as well, we've been giving patients more radiation dose in a single session and shorter treatment courses. The way we're able to give more radiation per day is that our machines are much better. Our technology has improved to the point where we can pinpoint that dose, put it where we want it, and have very little radiation going to the surrounding structures.
Whereas in the early days of radiation, such a big dose would have been toxic.
It would have been toxic or even fatal.
Yeah. But you have it like a laser sight.
Not exactly laser right now, but that's coming.
Yeah.
But we have it pinpointed enough where we do very little harm to the surrounding structures.
Well, and we talked about your interest in the technology. So when you're able to do this, and when you're able to chart the progress and keep up with the advancement of technology, it's got to be exciting and satisfying.
It's very exciting. Radiation, it's like computers. Where computers, the memory doubles every
what is it, Moore's Law, right?
Yeah, Moore's Law. Yeah. Radiation follows Moore's Law, where our ability to pinpoint and target cancers and give less dose to the surrounding structures has just exponentially gotten much better over the years.
It's time for a quick break on Focus on Your Health. We'll be back in a moment for more with Dr. Michael Payne. Support for the Arizona Community Radio Network is provided by Kingman Regional Medical Center. KRMC is pleased to welcome Anna Sammons, nurse practitioner at KRMC Pain Management. She provides care for patients with chronic pain conditions. To make an appointment with Anna Sammons, call KRMC Pain Management, 681-8570. Welcome back to Focus on Your Health. I'm T.G. Lafredo, and this week on the program, my guest is Dr. Michael Payne. He's a radiation oncologist at KRMC. You've been practicing medicine since 2004.
Yes.
In the 16 years, you've seen a lot of changes, obviously, because we're talking about Moore's Law in action. Yes. So as you think about those changes and kind of think about what's ahead, specifically in radiation oncology, what do you think? Where's it headed?
So I think all of oncology is headed toward something called precision medicine. And that's a buzz term patients, or if you may have heard before. Precision medicine is individualizing the cancer treatments. So before, we did studies on lots of patients, and everybody got the same treatment. And some patients did well, some patients didn't do well. But we all know, doctors know that everybody's different. Everybody's an individual. What's in us is not the same as in somebody else. And the way we react to a treatment may not be the same as somebody else reacts to a treatment. We also learned that not all cancers are the same. Somebody may have a breast cancer, but those two breast cancers can be completely different. And so they have to be treated in different ways. And so our treatments, both in medical, surgical, and radiation oncology, are all headed toward an individualized treatment. There are different ways to individualize treatment, but as far as radiation is concerned, it's taking treatments and individualizing for that cancer and that patient, the dose, how many they get, and how many days. We're still in an era right now with radiation where we still treat sort of like a cookbook where everybody gets sort of the same thing. But as time goes on, I see that differing enough that each patient is going to get a different treatment course based on the type of the cancer and the genetics of the cancer.
Traditionally, this has been, kind of looking at a bell curve. These patients tend to do well with this treatment, so this is what we'll do, right?
Right, the majority.
Yeah, and how do you continue to dial in that customized approach?
Well, the most common way now is genetics. We look at genetics of the person and genetics of the tumor. Genetics of the tumor can give us all sorts of information, and medical oncology is very exciting because they're using individual changes in the DNA or even a nucleotide to make a medicine that will target that and will take care of the cancer in ways that we haven't seen, and take a patient who's stage 4 and make the cancer disappear, and we never knew they had cancer. And another one, before that, those patients died. Yeah. Or using our own immune systems in the fight with the cancer. That's another big thing that we're looking at now, immunotherapy. Yeah. Where we prime our own immune systems to fight the cancer. With
nuclear medicine, you're able to get the thumbprint of what's wrong, right? As opposed to trying to make these big course attacks on the body.
That's right. With genetics, we're looking at the genetics of the individual tumors. We're able to find whatever made that cell become a tumor, or makes that cell grow faster, and using it against it.
It's got to be a very exciting time to be practicing medicine.
It is very, very exciting.
I want to ask you a little bit more about Sbrt, which we mentioned is stereotactic body radiotherapy. I know that this is commonly used for prostate cancer.
It is.
Is it right for all cases of prostate cancer?
It is not. So Sbrt is currently used mostly, standard of care is for patients with what we call low risk or intermediate risk prostate cancers. There are studies going on using it for high risk patients as well. But mostly it's used for lower and intermediate risk prostate cancers. It's an exciting treatment because prostate treatment used to take 9 to 10 weeks of radiation every day, Monday through Friday. And that's the way patients were treated before I came here. Sbrt reduces that down to 5 treatments. Wow. And they're treated 2 or 3 times a week, so it takes usually 1 or 2 weeks to do. the great thing about that is the studies show that the results are exactly the same.
And your qualitative research, your practice of medicine bears that out. You're seeing that as well.
Yes, I am definitely seeing that.
Are you treating patients with this right now? Like
I
as
am.
we speak?
We started our Sbrt program for prostates here in Kingman when I started, and patients love it. It's 5 treatments, and also they noticed that they some patients notice they get less side effects.
That was my next question. It sounds faster and easier, but what kinds of side effects are you talking about?
So the side effects, radiation is radiation, so the side effects are generally similar to the side effects they would get even with the 9-week or 10-week treatments.
Yeah.
But they get sometimes they get a less duration of those side effects, and it's not as severe as it would be in the 9 or 10-week treatments. We're also treating Sbrt in lungs here as well, for patients who are diagnosed with stage 1 or stage 2 lung cancers, which we're finding more and more of because we're doing screening CTs for patients who are high risk.
Right. Does this technology, will it avail itself to other kinds of cancers as well?
It does. We are also doing it for brain tumors as well,
Wow.
Both metastatic and primary brain tumors. It's been used in a lot of other cancers as well. You can use it in pancreatic cancer, even metastatic cancers you can use it in as well.
Well, Dr. Payne, when you first started here at KRMC, I got a press release about you, and it talked about a little bit about who you are and where you're from. And there was a line in there, a quote from you about treating cancer patients, and that was, "I believe in the whole person approach. Diet, attitude, and lifestyle play important roles." I want to ask you a little bit about the whole person approach because you correct me if I'm wrong. I feel like so much of medicine, especially when we get the insurance, that's our favorite scapegoat, the insurance companies involved.
Right.
It's process mentality. You've got a line of patients, you got to get them in, get them treated, and get them out. But that is like the opposite of that personalized care that we've been talking about here on the program. Yeah, go ahead. So when you talk about that whole person approach, what does that look like?
So the whole person approach is dealing with the patient as a person. Dealing with the patient like they're a family member, a loved family member.
Not that family member, but this one.
And so we know that, yes, we can throw treatments at patients, but treatments have side effects. Treatments do things to the person's both physically and mentally.
Yeah.
And so we know people need that whole body approach. They need that support system. And that whole body approach includes your nutrition. What are you eating? How are you eating? Are you losing weight? Are you gaining weight? And mentally, how are you doing? How are you taking a diagnosis? Do you have support system? Do you have somebody around to help you, at least mentally, deal with this? Do you help if you need help to deal with this? Also, physically, how are you doing physically? Are you able to get up and walk? Some people have patients who can barely stand, but they say, "I'll get out and I'll walk a block and I feel so much better."
Yeah.
And so I think all of that helps the person in dealing with the cancer. We say immune system is very important in dealing with cancers, and it is very important. And our immune systems respond to what we eat, our physical activity level, and how we feel. That's why people who are depressed, there are studies that show people who are depressed actually get more colds.
Yeah.
That's why winter is a big time. I mean, it's not only the air conditioning system, the heating system that putting germs in people, but it's also being locked in the dark in a house
Lack of
by yourself,
sunlight,
lack of sunlight, lack of physical activity.
Yeah.
It also leads to that as well.
Yeah, Chicago and Buffalo for
Exactly.
two prime examples. And some aspect of that, at least for many patients, is a kind of a spiritual aspect.
Definitely, I didn't mean to leave out spiritual, but spiritual is also very important.
I mean, they're confronting their own mortality.
They are.
And you're not a pastor, but do you talk about that? Like, hey, think about or seek this help somewhere? Or
I do talk with patients about that, and everybody. I mean, it doesn't matter who you believe in or what you believe in. Yeah. It does help, or if you believe in anything at all. When patients are facing their own end of life, or have an end of life diagnosis, or diagnosis that can be terminal, they start thinking about the spiritual and what comes next. And it can be, praying to your God, or as simple as just meditating and clearing your mind.
Yeah. I want to ask you, this is kind of a personal question, but I think I have your blessing from earlier about this, but you, as we're saying, you're dealing with people you're trying to help them, and they're confronting their own mortality. And I know that you get to take part in a lot of happy stories and people recovering, but obviously in this line of work, there are tough days, there are losses. How do you deal with that?
The way I deal with it, first of all, it is tough. And so when I tell people what I do, their first reaction is, that must be really hard. And I don't think of it that way. In my mind, it's not hard because I know that I'm helping people. I'm either helping you beat cancer, or I'm helping you deal with a symptom because you're in life and it's something that's decreasing your quality of life. Yeah. And so in that sense, it's a happy job for me. It's not something depressing. But you do get close to patients. It's hard not to. And patients die. And the way I deal with that personally is I do believe in God, and so my spirituality helps me. I also, when I'm not here practicing, I like to just be away from cancer and the cancer center. So I like to do other things, travel, seeing other cultures, physical activity, mountain biking, hiking. So,
yeah, being right up close and personal with some of these difficult stories. Do you feel like that gives you a heightened appreciation for those times away, the great outdoors and those other interests of yours?
It does, because the old cliche, life is short. Yeah. So life is relatively short compared to how long the Earth has been here and how long other beings live. And so my philosophy is to make the most of every day.
Dr. Payne, as you look ahead to what may happen in oncology, but specifically here at KRMC, you bring a lot of ideas, a lot of experience. I don't want to get you in trouble here, but as you think ahead, what would you like to see, or what would you like to bring forth here at the Cancer Center?
I would love to do what Dr. Rivera has a great medical oncology program here, and that most patients don't need to go to Phoenix or Las Vegas to get world-class treatment, because they can get it here in Kingman. And that's where I want to bring the radiation program as well, where you don't have to go to Phoenix or Las Vegas or California or whatever to get world-class treatment. You can get it right here at home. And in doing that, I'm introducing stereotactic radiation treatments, which you can get in Las Vegas or Phoenix, but why not stay home and get it?
Yeah.
I also want to look at doing a brachytherapy program with a brachytherapy is a procedure where you place radiation directly into the cancer, and it's helpful for some cancers. And right now, our patients have to go to Phoenix or Las Vegas to get that portion of the treatment done. I would love for them to stay home and get that done. And I'm always looking at ways to expand our technology. There's a new breast treatment that we hope to be doing soon called prone breast treatment. Right now, our ladies are treated, their breast cancers are treated where they land on their back. If they land on their stomach, there's some physics that help pull the breast away from the chest wall, and so the patient gets less radiation dose inside their body while still doing the same job for treating the breast. And so we're looking at doing that as well. So I'm always looking at improving and bringing technologies here for our patients.
That's Dr. Michael Payne. He's a radiation oncologist at the W.L. Nugent Cancer Center at KRMC. Dr. Payne, thank you so much.
Oh, thank you. I appreciate it.
And that's the program. That's Focus on Your Health. I'm T.G. Lafredo. Thank you for listening. We'll catch you next time.